On the head and neck cancers. We will be discussing this in two parts. Head and neck cancer, it includes the subsites of lip, oral cavity, the pharynx, larynx and the paranasal sinuses. Also, the occult primary of your neck nodal disease alone is also covered under this, along with your salivary gland cancers. The initial part we will be discussing more of your localized disease and its treatment. Squamous cell carcinoma and its variant other histological types of your squamous cell carcinoma contributes to more than 90% of all of your head and neck cancers. As we know, the most important risk factors are the tobacco abuse and the alcohol for all your oral cavity, hypopharynx and laryngeal cancers, and also HPV unrelated oropharyngeal cancers. So as this sentence signifies, the other risk factor is your HPV infection, more so for your oropharyngeal cancers. Entire aerodigestive tract epithelium can be exposed to this carcinogens. It does not mean that when you are having a oral cavity cancer, you do not carry a risk in other areas. As we know, this tobacco exposure is uniform right from your lip to your esophagus, stomach and so on. So this is called field cancerization, the risk at which the other areas of this aerodigestive tract which is exposed to such an agent might develop a cancer in the future. This is called field carcinogenesis. So if a patient has a problem in the tongue or in a floor of mouth, he also has future risk of developing cancers in this aerodigestive tract. So that can be a synchronous primary tumor. You can have a tumor in the tongue and also in the esophagus, or you can develop future second primary neoplasms in your head and neck, lung, esophagus and other sites which share these risk factors. This is called as field cancerization. So far we have discussed tobacco as important risk factor for development of head and neck cancer. The other important risk factor is your HPV infection. The oropharyngeal cancers are more so associated with this HPV infection, more so for your tonsils and your base of tongue lesions. Very small subset of oral cavity, larynx, nasopharynx and sinuses can be HPV positive. So in head and neck cancers, HPV positive subset is your oropharyngeal cancers. Not that others are never going to happen with your HPV. There is a small subset of all other sites also which can happen because of this HPV infection. And more important is that at least 50% of this unknown primary in head and neck are HPV positive. So after oropharynx, the most other important subset of patients who have a high probability of carrying a HPV positivity is your unknown primary of your head and neck region. Basically these patients tend to be younger as compared to patients who are having tobacco as their risk factor. We know that HPV gives rise to many proteins inside the cell, and one such protein is your P16. So trying to diagnose HPV associated cancers, you can either diagnose HPV virus per se or the presence of P16 through your immunohistochemistry. So this is a protein. So this protein presence can be diagnosed with the IHC, or the virus can be diagnosed with your genetic methods to know whether the patient has an associated HPV infection or not. The strongest causal relationship has been found with oral HPV 16. The other HPV 18, 33 and 35 are responsible for the other majority of the lesions. The important mechanism by which this HPV positivity leads on to cancer is that the oncogenes E6 and E7. E6 leads to the inactivation of P53. So E6 leads to P53 inactivation, whereas E7 leads to inactivation of your PRB or your RB gene. So this is how these two tumor suppressor genes are being targeted by your oncogenes which are activated by your HPV infection. So HPV infection activates the oncogenes E6 and E7, which will then inactivate your tumor suppressor genes the P53 and the PRB respectively. Non-oropharyngeal cancers, currently there is no recommendation for testing for a HPV infection. The recent FDA guidelines and the NCCN guidelines tells us that vaccination prevents HPV related cervical and anal cancers. The FDA has expanded its indication for vaccination for oral HPV infection and related cancers as well. So far, the data has told us that we are not having any benefit of this HPV infection for the oropharyngeal cancers. It means that the HPV vaccine is beneficial more for your cervical cancer and all your other gynecological cancers which are associated with your HPV. On the other hand, though we are finding that oropharyngeal cancers can be associated with HPV, vaccination against HPV has not prevented this oropharyngeal cancers in most of the trials. But just because we have found out that your cervical cancers and also your anal cancers are prevented by this HPV vaccination, FDA has now expanded its indication for the vaccine against oral HPV as well. Any locally advanced HPV positive head and neck cancer has improved response to the treatment. So just because patients are HPV positive, same locally advanced tumor versus a HPV negative of same tumor burden will differ in their response to treatment and the survival. So for example, a patient with a T3 lesion, if he is HPV positive, will be doing well both for the prognosis and also for treatment response when compared to the same T3 which is HPV negative. So improved response to treatment and survival as compared to your HPV negative tumors. Tumor patients receiving radiation or chemoradiation will have improved response if there is HPV positivity. But on the other hand, if smoking is associated with this HPV positivity, the advantages of being HPV positive are negated. So they have a poor PFS and OS, that is your progression-free survival or your overall survival regardless of your P16 status. So P16 is going to correlate with your HPV positivity. So these two are the major risk factors for your head and neck cancers. Now let's go on to stage a patient with the head and neck cancer. Staging a patient with head and neck cancer is very important for all our subsequent discussion purposes. Staging can be of either, so staging, now what you are going to discuss is your oral cavity. So oral cavity staging, most important is your T staging, N staging and also your metastatic staging. So the T staging is important for your oral cavity. I am talking in terms of your exams. N staging is going to differ for oral cavity, HPV negative, oropharynx and so on will have a different set of N classification as opposed to your nasopharyngeal. So your nasopharyngeal cancers and your oropharynx, which is HPV positive, will have a different set of nodal classification. So here what you are going to see is your T staging of your oral cavity first. It has T1, T2, T3 and T4. This is based on two parameters, the depth of invasion and the tumor size. So the tumor size and the depth of invasion, there are two parameters which are taken into account for staging a patient with the oral cavity cancer. So when the size is taken into account, T1, so here we are describing T1, T2, T3 and T4. When your size is taken into account, less than or equal to 2 centimeter, 2 to 4 centimeter and more than 4 centimeter or stages T1 to 1 to 1, 3. The T4 has a different classification. When you are taking your depth of invasion, DI or your depth of invasion as your criteria, anything less than or equal to 5 millimeter in your depth is stages T1. more than 5 millimeter and less than 10 millimeter is as T2. Anything which is more than 10 millimeter is T3. So T3 can be either of these two. As we have seen, anything which is more than 4 centimeter can be a T3 lesion, or more than 10 millimeter thickness can be a T3 lesion. So it means as that a patient with this size and this depth of invasion will be qualifying for T3. So this is how we are supposed to interpret this. So this is about size and your depth of invasion for interpretation of your T staging in oral cavity. So that is being described here. A tumor of more than 2 centimeter, more than 2 but less than 4. When the depth is more than 10 millimeter, it becomes T3. So this with this will be called as T3 lesion. Okay. So this is how you are going to stage a T stage in your oral cavity. Now coming to the description of your T4 lesion, which is more important for us to remember. More for competitive exams is here T4B lesion, which is having 3 criteria: invasion of masticator space, pterygoid plates or skull base, and one more, indication of internal carotid artery, not the external carotid artery, it is the internal carotid artery. So any invasion of these 4 structures, any of these 4 structures will qualify for T4B. Having said this classification with numbers, a T4A is more than 4 centimeter and more than 10 millimeter. So when these two are combinedly present, then it will be T4A. So more than 4 centimeter with the depth of more than 10 millimeter is T4A. Or adjacent structures like your cortical bone of mandible maxilla or maxillary sinus, skin, all these adjacent structures which are not in the category of inoperability will be called as T4A. So let's discuss this T staging again. So T staging in an oral cavity has T1, T2, T3 and T4. It has 2 parameters to be taken into account: the size and the depth of invasion. The size here which we are talking about is less than 2 centimeter, less than or equal to 2, 2 to 4 centimeter and more than 4 centimeter. The depth of invasion which we are talking here is the depth of invasion can be less than or equal to 5 millimeter, 5 to 10 millimeter or more than 10 millimeter. So here T3 is this or this. So when this is present and you have this, you will be calling it as T3. When this both are present, means and more than 4 centimeter and more than 10 millimeter, then it will be called as T4A. This is what the size and the depth of invasion criteria for us to remember. And the other one to remember is your T4B invasion and where all it invades. So what is this depth of invasion? See, when this is the basement membrane, from the basement membrane to the tip of the last tip of your tumor will be called as the depth of invasion. Here again this is the basement membrane to this is the last tip. This will become the depth of invasion, whereas this is your tumor thickness. So tumor thickness is not your depth of invasion. So this is your tumor thickness. This will not be called as a depth of invasion. Depth of invasion is always from your basement membrane to the last tip of the tumor. So this is your T stage classification in your oral cavity cancers. Coming to the end stage classification, you now have broadly known that end stage classification is same for your HPV positive oropharyngeal cancers and your nasopharyngeal cancers. More or less the same, a minimal difference between the two. Now what you are going to see is the oral cavity, that is basically you are discussing here the non-HPV cancers of your head and neck. Here end stage stands for, the end stage can be N1, N2 or N3. N1 is single ipsilateral lymph node. N2 has A, B and C. N3 has A and B. Easy for us to remember is N3B, which is any node which has a clinically overt ENE. What is ENE? ENE is extranodal extension, either clinical or pathological. Here what we are discussing is a clinical extranodal extension, means the tumor which has come out of the node is being detected by us clinically. How can we do this? Any node which has a fixicity to the adjacent structures means the node has an extranodal extension. If whatever may be the size and whatever may be the site, if there is extranodal extension, that will be called as N3B. On the other hand, all the other parameters will have a size criteria and the site criteria for us to understand whether they are N1 or N2. So what is N1, N2, A, B and C and N3A. N1 is, let us take that this is the patient who has a right sided lesion. So this is your tumor. Let's consider this is the tumor. So this becomes the ipsilateral side. This is your contralateral side. So N1 is any ipsilateral lymph node which is less than or equal to 3 centimeter. Which is less than or equal to 3 centimeter. Whereas N2A means same ipsilateral lymph node which is 3 to 6 centimeter. 3 to 6 centimeter. On the other hand, if the nodes are less than 6 centimeter but multiple ipsilateral lymph nodes. So same. So less than 6 centimeter but multiple ipsilateral lymph nodes. So less than 6 centimeter and multiple will become N2B. N2C is presence of either bilateral or a contralateral node which is less than 6 centimeter again. Anything which is contralateral and less than 6 centimeter. So bilateral or contralateral lymph nodes none less than 6 centimeter is your N2C. N3A is a node which is larger than 6 centimeter. So anything which is more than 6 centimeter will be called as N3A. N3B, as we know, has a extranodal extension. This is how you do a nodal staging for a patient with cavity cancer. Now coming to the nasopharyngeal cancer and its staging. Nasopharyngeal cancer staging is not so important when you come to the T staging. T staging in nasopharynx can be based on the invasion of the adjacent structures. The most important for us to remember is the end staging, which can again be questions for us. End staging in your nasopharyngeal cancers, when you know it is N1, N2 and N3, there is no ABC classifications in this. If there is a tumor which is present this side, now let's take this as the tumor, cricoid cartilage, and this is the lower border of your cricoid cartilage. So an N1 tumor is an unilateral cervical node or your bilateral retropharyngeal nodes. Can be unilateral or your bilateral retropharyngeal nodes. So this can be an retropharyngeal node. This is a cervical node which is less than 6 centimeter again. N2 is a less than 6 centimeter again, but it is bilateral cervical nodes. So bilateral cervical nodes less than 6 centimeter is a N2 disease. N3 disease is nothing but your any node which is more than 6 centimeter or it is below the cricoid cartilage, lower border of your cricoid cartilage. So either lower border of cricoid cartilage or it is more than 6 centimeter becomes your N3 node. So this is how a end staging in your nasopharynx is going to be important. Same way, when it comes to the oropharyngeal cancers, P16 positive oropharyngeal cancers, again the similar kind of N1, N2 and N3. Easy to remember for us, anything which is ipsilateral less than 6 cm is N1, contralateral or bilateral less than 6 cm is N2, more than 6 cm of any node is N3. So this is how a P16 positive, that is your HPV infected oropharyngeal cancer, is going to be important. So now coming to the stages of your head and neck cancers. When you discuss the staging in your head and neck cancer, in your initial stages of, basically how do you stage 1, 2, 3 and 4 of your oral cavity cancer differs from staging in your nasopharyngeal cancer and also your oropharyngeal P16 positive cancers. Stage 1, 2 and 3 here, all of them include the node positive diseases, whereas in oral cavity cancer it is not the same. So being node positive can still be a early stage disease when it comes to the P16 positive oropharyngeal cancer or your nasopharyngeal cancers. Means that even a node positive subset can be an early stage disease if they are P16 positive. And coming to the final staging for us to remember is your unknown primary. In unknown primaries, what you are going to see is only neck nodes. So neck nodes are again staged according to as you staged a oral cavity cancer, with your N2 having N2 ABC, N3 having N3A and N3B. Here it can have a clinical extranodal extension as well. Otherwise the staging is going to be same as your oral cavity nodal staging system. Once you know that you have an oral cavity or any of your head and neck cancers and your biopsy is showing a squamous cell carcinoma, so you are calling this as head and neck squamous cell carcinoma. How do you stage? What do you do for the staging? And also what are the metastatic workup? You can either do a CT or MRI for your primary tumor staging. If you want to know about the nerve infiltration, the muscle infiltration and so on, your MRI is going to be useful. If you want to know the bony structures which are invaded, like your bony cortical invasions and so on, CT is going to be useful. For a neck node and your metastatic workup, it has been found that your PET scan is going to be more beneficial as compared to your normal CT scan of your chest and your neck. So for metastatic, there is high chance that the patient can be metastatic, and then you do a PET scan rather than a plain CT scan. Now coming to the treatment of these patients. A patient with the stage 1 and stage 2 tumor can go for any of the single modality local treatment, can be either surgery or a radiation. So surgery is always better if the patient is operable. If you have a cancer in the oropharynx or your base of the tongue and so on, where surgical operability is questionable, then you can do only with your radiation. So radiation as a single modality is enough when you are dealing a stage 1 and 2 tumors. Now we are discussing head and neck cancers in total, not separate as you staged separately now. So any stage 1, stage 2 tumors can be treated only with a single modality of treatment, either surgery or radiation. Surgery is the preferred modality if the patient has an operable lesion. If you need organ preservation, or if the patient has an unresectable subset, something in your nasopharynx, then radiation is going to be beneficial. On the other hand, locally advanced tumors, that is your stage 3 and the stage 4A, these tumors are going to be should be treated with combined modality therapy, which includes surgery, radiation and systemic therapy as well. So all these three modalities have to be sequenced according to the patient's requirement and the patient's disease status, but all these three modalities are to be incorporated for a better survival of these patients. Now let's discuss on each one of this. Surgery, obviously any patient who has an operable lesion will get a wide local excision with reconstruction. This is the treatment for a about the primary disease. When it comes to the neck dissection, a patient who has a tumor in the tongue or tumor in the gingiva or any of the oral cavity tumors, how are you going to address the neck? Previously, how it was described was to have a radical neck dissection and otherwise a modified radical neck dissection. These were the previous terms. So, modified radical neck dissection or MRND can be of three types. The type 1 wherein only the accessory nerve is preserved. The nerve and vein are preserved in your type 2. The nerve, vein and muscle are preserved in your type 3. This is your modified radical neck dissection. Basically, you are trying to preserve those structures which are not involved by the tumor, thereby preserving the function of these structures. The current classification is either comprehensive neck dissection or a selective neck dissection. What is comprehensive neck dissection? It removes all lymph node groups. It is similar to your radical neck dissection. Whether you are going to preserve the nerve, vein or muscle will not affect the dissection as classified or not. So what are we trying to understand from this? Previously we had a classification of radical and your modified radical neck dissection. Current classification is comprehensive and selective neck dissections. Comprehensive neck dissection means you do similar to your radical neck dissection, but if you preserve the nerves or vein or muscle or all three, will never make them non-comprehensive. Means that even in comprehensive neck dissection you can preserve these structures. So all your radical and your modified radical are now called by a single term called as comprehensive neck dissection. It is usually recommended for your N3 diseases. What is selective neck dissection? Development of this selective neck dissection is mainly for your N0 tumors. Basically means that you are not clinically palpating any neck nodes. So a patient is having a tumor in the oral cavity, neck nodes are negative on clinical palpation. So N0 disease, here by understanding the pathways for the spread of these head and neck cancers, trying to remove those regional lymph nodes is called selective neck dissection. For example, in an oral cavity, nodes above the omohyoid muscles, the levels 1, 2, 3 and sometimes the superior part of level 4 are the nodes to be removed for your selective neck dissection. Means that a patient is having an oral cavity cancer but the neck is negative, so N0 neck. So N0 neck with an oral cavity cancer should have selective neck dissection which dissects all your levels 1, 2 and level 3 nodes. So this is how a selective neck dissection is done based on the pathway of spread for these primary tumors. For on the other hand, if it is a pharynx or laryngeal tumors, a level 2 to level 4 and level 5 is also included in the selective neck dissections. By this concept has evolved because when you have an N0 neck, the chances of a node being positive outside this selective neck dissection area is less than 10%. So when there is no clinical nodal involvement, these tumors rarely present with nodal mets beyond the confines of your appropriate selective neck dissection. So what are you trying to understand? Anyone who has a N0 neck, you have done a selective neck dissection, the chances that a node which is not in the area of this selective neck dissection to be positive is less than 10%. So this is the concept of selective neck dissection. So why do you do selective neck dissection when there is no clinically positive nodes? Are we going to treat these nodes which are clinically negative? Certainly not. What we are trying to determine is the subset of patients who are candidates for possible adjuvant therapy. Means what? So now take a patient who has a oral cavity cancer. Here you have done a primary surgery. You have done a wide local excision with a reconstruction for the primary lesion. But now also the patient has an N0 neck, means that there is no clinically palpable lymph nodes. The aim of doing a selective nodal dissection is to find if there is any positive node. If the node is positive, then the patient is supposed to undergo your adjuvant therapy. So, the purpose of doing a selective nodal dissection is to find your patients who are going to need your adjuvant therapy. But on the other hand, it can be therapeutic also when the tumor burden is low. Means if the tumor burden is like N1 disease, very small nodes, your selective neck dissection can again be done, just because it is going to take off those nodes, you are not going to get a recurrence in those areas. So it can be a therapeutic modality as well. So selective neck dissection means you are going to remove the nodes which are the major draining areas of that subset. You are not going to remove the nodes which are beyond this confined area. So in this selective neck dissection, you are targeting to find the nodes which can be positive. If you are doing in an N0 neck, you are doing to find if there is a microscopic disease in that node. Finding a microscopic disease in the node will let us know whether you are going to use the adjuvant therapy, either systemic therapy or radiation. Just removing these nodes are not going to be therapeutically helpful. On the other hand, if the patient has an N1, N2 disease, more so for an N1 disease, doing a selective neck dissection instead of a comprehensive neck dissection will be both therapeutic. You are going to remove the nodes, that is going to be therapeutic in that area, and also it will tell us whether you are going to use an adjuvant therapy or not. In general, any patient who is undergoing selective neck dissection should not have a clinical nodal disease. But to prevent the morbidity, instead of using your comprehensive neck dissection, if there is a low volume nodal disease, you can use your selective neck dissection. That is how SND is going to be useful in your patients. When the patients are clinically positive nodes, you are supposed to remove all the clinically positive lymph nodes and the other areas which are at high risk. Even your non-lymphatic structures which are directly involved by the cancer. If there is a muscle which is involved, remove the muscle. That is how you are going to address a clinically positive lymph node. Whether you are going to do an unilateral dissection or bilateral dissection it depends upon the location of the tumor and the extent of the tumor. Any midline structures, like example, a patient who has a tip of tongue cancer or a base of the tongue cancer, there is a high chance that he will have a bilateral neck nodal metastasis. Then in such patients you can do a bilateral neck dissection, as opposed to a lateralized lesion wherein there is very high chance of an unilateral metastasis. You do a unilateral neck dissection. If either imaging or your FNA is identifying a node bilaterally, then you are again supposed to do a bilateral neck dissection. This is how you are going to address the nodes in the neck. So far what we have done the surgery for the primary tumor, we have addressed the neck. What next? You are going to do the post-operative management. Post-operative management mainly for your high-risk diseases. There were 2 trials which address this question. The inclusion of these 2 trials, the common parameters which were used in both the trials were margin positivity and extracapsular extension. So these 2 were the common inclusion criteria of these 2 trials. The RTOG trial, though not to remember the heading, this included only one other variable, the positive nodes, whether it is more than 2, if there are more than 2 nodes which are positive, those were included. In the EORTC trial, 4 other parameters were also taken into account for inclusion criteria, like your vascular embolisms, perineural disease, stage 3, stage 4 of any disease, oropharyngeal or oral cavity with a level 4, level 5 lymph node. So these were the other inclusion criteria to know whether patient should undergo radiation alone or chemo with radiation. So this was the trial question. And what did this trial answer? The trial's answer was that these two common subsets as common variables. So if a patient has a margin positivity or an extracapsular extension after surgery, then they are supposed to undergo chemotherapy with radiation therapy. So extranodal extension and your with or without positive margins will be the indications for post-operative chemoradiation. On the other hand, any multiple positive lymph nodes, perineural vascular lymphatic invasions, or a T3, T4 tumor, or the oral cavity or oropharyngeal tumors with level 4, level 5 nodes. So what are these? These are the inclusion criteria for your EORTC trial. So these patients, the patients with these criteria were taken into this trial for seeing whether this will work or this will, which is beneficial basically, which is going to give a survival benefit. So basically all these subsets were given radiation invariably. Whether or not chemo addition is going to be beneficial was proven only in these two, that is your margin positivity and your extracapsular extension. So obviously these other subsets which have not benefited from chemoradiation will have advantage of radiation as well, because that is how these trials were designed and concluded. But there was a survival advantage in one of these trials even for these subsets with chemoradiation. So you can just consider. So not much into the confusions of this discussion. For you to do chemoradiation after surgery, you need to have either of these two, either an extracapsular extension or a margin positivity, with other criteria being fit or eligible only for your radiation than your chemoradiation. What is the chemotherapy which is used in your chemoradiation and what is the radiation dose to be used? In the post-operative chemoradiation, that these RTOG and the EORTC trials, the two trials which we have discussed so far, has told us that the RTOG and the EORTC trials used cisplatin at 100 milligram per meter square once in 3 weeks. So 3 weekly cycles of cisplatin at 100 milligram per meter square. So this becomes the standard of care for chemoradiation. The chemotherapy is cisplatin at this dosage. A recent Indian trial tried to use cisplatin at 30 milligram per meter square weekly instead of doing a 3 weekly 100 mg per meter square. The conclusion was that the 30 milligram per meter square was inferior to your 3 weekly 100 milligram per meter square. So, but only a disadvantage of 3 weekly cycle is the more toxicity associated with it. But on the basis of efficacy, 3 weekly cisplatin at 100 milligram per meter square is more efficacious than your weekly 30 milligram per meter square. So this is the standard of care for a post-operative chemoradiation. So the chemotherapy for this chemoradiation after surgery of the primary tumor and the neck nodal addressing is your cisplatin. When we tried other drug combinations like cetuximab with docetaxel, they were not more effective but they were more toxic. So these are not being practiced now. So this is all about your surgery and your post-operative management. Now coming to definitive CTRT. So any locally advanced disease, what are you going to do with this locally advanced disease? The locally advanced diseases can be approached with combined modality treatment, surgery followed by your CTRT or your RT. If patient is inoperable or patient has comorbids which make them medically unfit for surgery, you can do chemoradiation, that is your definitive. And if there is a residue at the end of chemoradiation, you can do a salvage surgery. This is how you approach a patient with a locally advanced head and neck cancer. Now in this we have discussed so far Here you are going to discuss the definitive CTRT. The definitive CTRT as the treatment of choice was established by a meta-analysis called McKenzie meta-analysis. This is a meta-analysis of many small phase 2 trials, phase 3 trials and so on, which tried to prove the point that CTRT is the best method for your locally advanced head and neck cancers. The trials which were included in this meta-analysis, which used induction chemotherapy, which we will discuss later, did not contribute to the survival benefit. So according to this meta-analysis, chemoradiation, that is a definitive chemoradiation, is the treatment of choice for locally advanced head and neck cancer. Again, here dosage of cisplatin used was 100 mg per meter square. The chemo used was cisplatin and the dosage used was 100 mg per meter square. And the radiation dose was given at 2 gray per fraction for a total of 70 grays administered over 7 weeks along with this chemotherapy. Lower dose of cisplatin 30 mg per meter square, same trial which we discussed in the post-operative management, as they also included certain upfront chemoradiation patients. We understood that this is not the standard of care. Rather, there are trials to tell us this dose can also be used, though not so important for our current discussion. So this is about chemoradiation in a definitive setting. We have so many patients with so much comorbids which make them ineligible for a cisplatin-based chemoradiation. What do you do in such patients? So in a patient has a locally advanced stage 3, stage 4 squamous cell carcinoma, if it is oropharynx, larynx and hypopharynx, then if you do radiation with cetuximab, it had a better control and better survival. This is mainly for patients who are not eligible for cisplatin. Again, concentrate that here we compared cetuximab versus radiation. You did not compare cetuximab versus cisplatin and the radiation. So logically you should have compared cetuximab with radiation versus cisplatin with radiation. But here it was just a comparison between cetuximab with radiation versus only radiation. What is this cetuximab? We know that head and neck cancers express more of a receptor, namely, so it is overexpression of epidermal growth factor receptors, EGFR. So the antibody against this receptor, so the antibody to this receptor is the cetuximab. So this EGFR antibody is your cetuximab. So as the name suggests, it's an iximab, means that it has a chimeric antibody, chimeric monoclonal antibody. So this is going to be helpful in patients who are not eligible for cisplatin. It had a better locoregional control and a better overall survival. The survival was very high with your cetux with radiation as compared to only radiation. When you added cetuximab to cisplatin, it is not recommended as it did not give any survival benefit. When cetuximab was compared with cisplatin, again cisplatin was better as compared to cetuximab. So when a patient is there, if he is eligible for cisplatin, you give cisplatin. If he is ineligible for cisplatin, we offer cetuximab. We know that the oropharyngeal subset has a better prognosis, more for a HPV positive cancer. When this HPV positive cancers, we can try to offer cetuximab with radiation as opposed to cisplatin with radiation. In this subset of patients who are doing well, when you try to de-escalate from chemotherapy to the targeted therapy. So we know that chemotherapy is toxic per se. So in a very good subset of patients, does this de-escalation of therapy means that instead of doing cisplatin with radiation, if you offer only cetuximab with radiation, in this good subset of patients, is it going to be helpful or at least non-inferior to that? All these trials were negative and cetuximab with RT was inferior to cisplatin with radiation. This is what we concluded. So none of the de-intensification trials were positive. So all of them were negative trials. So just because a patient has an oropharyngeal cancer which is HPV positive, you cannot deny the patient of cisplatin with radiation if the patient is fit for the same. Only in cases of unfit patients for cisplatin, you offer cetuximab with radiation. So the further part of discussion, we will take it in the part 2.